part of South
This
Asian.
meeting is being recorded.
Part of South Asian IBD Alliance, and South Asian IBD Alliance is to date the first organisation of its kind in the IBD space, which has been founded by patient advocates and multidisciplinary clinicians together. The mission within South Asian IBD Alliance is to create resources, research and education for IBD patients and healthcare providers of South Asian origin to minimise disparities, dispel stigma, promote early diagnosis and improve access to treatment. And with that, I will pass over to our gut experts to introduce themselves. We'll start with Professor Seb.
Hi there, thanks Sharon, Kavita, and it's great to be here, and I'm always very interested in participating in a clinician-patient partnership, think about various opportunities we have when we clinicians and patients work together, and this is one of those events. So I'm Professor Sebastian. I'm a gastroenterologist with special interest in ulcerative colitis and Crohn's disease, the so-called IBD, based in Hull University, teaching hospitals. And we are basically talking today about your digestive system and some common symptoms and common manifestations and common disorders. And we want this to be as interactive as possible. But I might start by giving you a little bit of a warning that if you have very sensitive stomach, whatever I'm going to show you in the next couple of minutes may make you feel somewhat like that. Hopefully it won't be my words which will make you that, but the pictures such as this. So I'm just going to briefly start with talking about how should be the consistency of your poop, what should be normal and what should be abnormal. This is so-called the famous Bristol stool chart, and I know I told to my little girl that can you actually identify what is the exact number of your poop, and she was quite interested in it. But in a way, the 3 and 4, the so-called sausage shaped with cracks on its surface, and the smooth and soft like a snake, they are supposed to be the normal or a healthy poo. Now, it's never going to be that all the time, but in the majority, that is the majority of occasions when you are passing your motions, that's what is normal. Then you have the other two extremes. So number 1, where you are really constipated, where you have literally like rabbit droppings, maybe separate hard lumps, or it may be mildly constipated, if you like, a little bit bumpy, but closer to 3 in that scenario, or to the other extreme, which is type 7, which is entirely liquidy or watery diarrhea. It may be just purely explosion of a water coming out, or it could be with or without blood as well. And then you have other milder forms of diarrhea with fluffy and mushy, etc., type 6. So that's a kind of poop. Now, I'm sure most of us don't look down onto the toilet bowl regularly, but when it is happening on a consistent basis for a few days, we'll always be conscious that our stool type has changed. So that's the first thing. Then it is about frequency. So there is no one frequency. It can vary from person to person. That is just your habit, what it has been for X number of years. But what is important is if that habit, what was normal for you, the number of times you have gone may have been 3 for the last 10 years, and suddenly it becomes 6 or 10, that's a difference. And then there is also about the time you actually spent actually doing the poop. And the average is considered to be 1 to 15 minutes. Again, if it is longer than that, one may think, actually, is it because you are needing to spend more time in the toilet? Does that indicate constipation, or are you having a sensation that you haven't completed? That means you are going many times, so you don't get off the toilet. So those are the two scenarios in which you think of the frequency. Then finally, about the color. So the normal color is considered to be brown, or sort of brownish gray color. So I've here given you some abnormal colors. Again, you may not look at your color of your toilet, daily. I don't think any of us do that. But if you are finding that, there is something unusually different, and particular interest is those three things which I have highlighted in the circle. That is, those who have blood in the stool. That means actually you are seeing blood that may be on the tissue, but then when you look down onto the toilet bowl, you can see that the water is become red, or you may find that there is actually streaks of blood in the stool which you have passed. That is clearly abnormal. And if it's purely red, that is abnormal as well. But although there are some food things which you eat which can make your stools red, classic thing is beetroot, for example. But apart from that, if you find blood, that's important. And equally important is this black or tarry and smelly stools. It's bit like what you see in the tarmac. If you have that sort of consistency stool, usually that means it is digested blood. That means bleeding from higher up in the tract. So those are the three colors which you need to be aware of. Particularly, why is that aware? I know you would have all been recently listening about the sad case of Deborah James, who had bowel cancer. And, it's important that polyps such as what is seen in the middle picture, or the cancers which are on the last picture, are detected early. And one of the commonest early symptoms is noticing blood. Of course, change in bowel habits itself may be a symptom. And why is it important to do that? Because most cancers develop as polyps. And if you deal with the polyps, then you can prevent cancer. And cancers at the early stages are completely curable, but not so in late stages. So I'm going to stop there and just give you a little bit of a quiz and encourage you to use the poll with this question. Which of the following is true? A, bowel cancer is more common in South Asians as compared to Caucasians. B, bowel cancer is the second most cancer killer in the UK. And C, bowel cancer occurs only in people over the age of 50. So do you want to vote now? That's it. Interesting. Yes, everyone has voted. Yes, it is indeed B. The bowel cancer is the fourth commonest cancer, but it is actually the second most common cancer killer in the UK. Bowel cancer is actually less common than Caucasians in South Asian. And surprisingly, it's actually more common in African Americans compared to other Americans. So yes, so B is the right answer. So one more poll to just get you into the mood. How many cases of bowel cancers could be prevented by healthier lifestyles? We are all bombarded now, isn't it? Starting from government to other organizations, we should all be, it's all our fault. Not all of it is our fault, but are there cancers in bowel cancer? How many of them can be prevented by healthier lifestyle. That means keeping a normal body weight, being a non-smoker, having good amount of fiber in the diet, etc. A, 50%, B, 30%, and C, 10%. Seems to have a mixture of thoughts. Maybe I have been too harsh on this one with regard to percentages, Sharon. So yes, it is actually nearly half of our bowel cancers, scientists have found that can be prevented. There are actually some things which we can actually positively influence as well. So well done all you. Sharon, back to you.
Thank you so much, Professor Seb. We do have a couple of questions that I just want to bring to you now. So what are the symptoms for polyps, and how would someone be able to recognize that so that they can potentially detect early?
Sure, great question. So first of all, not all polyps are symptomatic, or they may not have any symptoms. So currently in the UK, we have the National Bowel Cancer Screening Program. So when you turn 55, you should get a kit sent to your registered address. I would strongly, and it's a stool kit. You put a little bit of poop into that and send it back on the post to, it's done centrally. And if that is positive, then you'll get a call. Well, you will get the result, whether it's positive or negative, usually within a couple of weeks. If it's positive, they will invite you for a colonoscopy. Okay, so that is those are people who are not having any symptoms. Currently in the UK, it starts at age 55. In the US, it is currently 50. And it's likely over the next few years in the UK, it will go down to 50 as well. Okay, so that's one group. The other group is, Sharon, you're talking about the symptoms. So polyps may, have bleeding. There may be some change in bowel habits. It may be also patients who are present with what is called iron deficiency anemia. So your iron is low. Now, if you are a lady during the menstrual cycles, you may lose blood. There may be other reasons for you are anemic, but if you are having low iron related anemia, that is another thing, because it may be losing blood by trickles, which won't be visible. And so anemia may be actually one of the important symptoms, or iron deficiency anemia may be one of the important symptoms. The key thing is participate in the screening program. And if you do have any of those change in bowel habits, frequency wise, consistency wise, bleeding or anemia, or if you are concerned about some persistent symptoms, we all can get the order, curry flavored night and then have some diarrhea, but if you're having persistent, then always seek help. The important thing, one more thing, if I may add, Sharon, on that is, we all think that the moment we have any bowel symptoms, we will be sent for having somebody shoving up something up the rear end with a colonoscopy. That's not the case. Now we always do a stool test, what is called the FIT test, to determine whether you do need the colonoscopy or not. So there are some so-called non-invasive tests to be done first of all, and always your GPs will be able to do that.
Okay. And just to follow up on that, so if, for example, you have ulcerative colitis, then would it be difficult to determine if there are polyps there or not?
So ulcerative colitis, I'm sure Madhur may well cover, and Madhur do chip in about this. So in ulcerative colitis, the key thing to prevent colitis related cancer is keeping your condition under control, okay, because it's the inflammation which is the driver for development of cancer. And ulcerative colitis cancers more often than not are not what I showed you, that's big polyps. Okay, they go through a different type of cancer formation, so it's not necessarily polyp to cancer sequence like I showed you. And in ulcerative colitis, there are clear guidelines that when you are diagnosed, after 7 years after diagnosis, you will start on a so-called colonoscopic screening program. But the key thing in ulcerative colitis for prevention is keeping your colon healed. A healed colon, less chance of colon cancer. Regularly active colitis, your chances are higher. So it's an important message to convey with regard to colitis, that it's this grumbling irritation. The way I put it to patients is that, look, if your neighbor is irritating you for a few months, you might put up with it, but if it's few years, you might either leave the place or punch him or have a fight or something like that. So similarly, the cells of the lining of your bowel doesn't like this chronic grumbling irritation, and that's why colitis patients develop cancer.
So with IBD, would you say that even with that early detection to make sure that the treatment is effective can help prevent leading into colorectal cancer? Because
absolutely, that's a really important message, Sharon. In addition to all the health and lifestyle which I talked, non-smoking, keeping the weight steady, optimal weight, etc. Keeping the inflammation under control is very important in prevention. And in fact, some might argue that one of the criteria for a good center would be how many proportion of patients are reaching that so-called mucosal healing. That means they have less colitis-related cancer. It should be, colitis-related cancer should be consigned to history in my dream, and it's certainly in my opinion.
Okay, thank you. And I just want to touch on what you mentioned about this colorectal cancer being less common in South Asians. Do you feel that may be down to like lack of awareness, lack of education, and also kind of lack of uptake with the screening process, which could directly affect the numbers that we see?
Yes, that's an interesting question, potentially, but I think it is also, we do lots of things probably a little bit better in terms of diet. Our diet has got better fiber in some ways. Okay. Yes, there is a slightly higher, there is a cohort of South Asian population which has got higher than normal body weight. The smoking is actually less in South Asian community. So we are doing lots of things which are actually in some ways protective by nature or by design. So overall, I think the risk generally is lower, but when you talk about all these statistics and risk, we are talking about a population, but for an individual, for them, it's either 100% or 0%, you know what I mean? So it's equally important, irrespective of whether you are genetically or based on from where your risk is low, you still should look at periodically how your stools are. Don't ignore the symptoms. Participate in the screening program when you are invited for. And certainly, don't be afraid that all bleeding doesn't mean cancer. There are so many, could be just piles, which is much more common in South Asian population. It could be other things. It may be very simple things, but it's important to get it checked, because that's the difference between your life and, and you having a poor outcome if it's diagnosed later.
Of course. Thank you so much, Professor Seb. And going on from that, I'm going to move now to our next gut expert, Pooja. If you could introduce yourself, and Pooja will be going into and discussing around irritable bowel syndrome.
Thank you, Sharon, and thank you, Seb, for that presentation as well. I just want to thank all of the associations for coming together to allow us to kind of bring this presentation and to have this sharing of discussions. As Sharon mentioned, my name is Pooja, and I'm a specialist dietitian. I specialise in gut and bowel diseases and disorders and South Asian diets, and I'm also currently fortunate enough to be a PhD student. So I will be just briefly discussing a little bit about IBS. Thank you for getting the presentation up. So in terms of the symptoms and what is IBS and just everything kind of related to it, we're just going to briefly touch upon all of these things, because when you're talking about these conditions, we could literally be talking for hours, because there's so much research, there is so much to talk about within it. So IBS is defined as abdominal pain or discomfort which is associated with an altered bowel habit. So that could be, for instance, constipation or diarrhea, which lasts for at least 6 months. And it is described as a long-term condition of the digestive system. It's not known as being something that occurs short-term or perhaps just passes. It is known that it's something that could, impact a person for the rest of their life. Next slide, please. So in terms of the symptoms of IBS, these vary person to person, and there's so many different symptoms that can occur. In each individual, it may be that you get one symptom, two, or you get a whole host of them. It's really difficult to say because it varies so much. So one of the symptoms may be the stomach pains, cramps, and that's usually worse after eating or better after, for instance, your bowels opening. There may also be constipation, which would feel like, you're having to strain. It's quite difficult to actually pass that motion and feeling like the bowels aren't emptying fully. Bloating, where the stomach feels distended, it's come out. It could feel uncomfortably full, swollen, and also tiredness can come with those as well. And there may be days when symptoms are better or days when it's worse, which we refer to as flare-ups. And the triggers of these could be related to so many different things. But one of the key ones that's quite commonly mentioned is being triggered by food and drink. The symptoms can also come and go over time. They could last for a few days, weeks, or even months at a time. And given that the symptoms can vary person to person, we have a classification for the IBS, which would be, for instance, someone who's got more constipation-related symptoms. We may refer to that as IBS-C. Or if it's more diarrhea prevalent, then it might be referred to as IBS-D. And then we've also got the mixed one, which is where you have a multitude of symptoms. In terms of the diagnosis of IBS, there's no formal test for it, but the doctor or GP may want to complete some other tests to rule out other causes. So for instance, they may test for celiac disease, just because the symptoms do overlap in terms of the bloating, loose bowel motions as well, the change in bowel habits. But it's likely, especially if you've got a history of autoimmune disease in your family, so for instance, from type 1 diabetes or celiac disease, that they would be more likely to test for that as well. They also may do a stool test to test for, infections or IBD. But again, it would really depend on what symptoms you're having. And generally speaking, there wouldn't really be any further tests in the hospital unless the GP isn't sure what the problem is, or that the symptoms perhaps are alarming or not typical of just IBS. Alongside this, it would be helpful to do a diet history in which you collect, in that day, what you've eaten, to look at if there's anything perhaps triggering it. And that's something a dietitian would be involved with trying to pick out if there's something specific. I would say it's really important, if you have got any of the symptoms mentioned, to go and see a GP and not to self-diagnose, because I think that is becoming more and more common, especially when I'm talking to people and they're saying, oh, I've got IBS, but not had the formal process potentially, so not able to get all of the support available. And I think, as we've discussed as well, it's perhaps sometimes common for those from South Asian populations not to go see the GP or to go get tested and things like that. Next slide, please. So in terms of the treatment of IBS, as I've mentioned, a food and symptom diary, and that's to highlight any trigger foods. So for instance, a dietitian might look out for, the lactose or gluten, or the amount of fat and how high the fat is, what type is it, saturated fat, to see if there's any patterns, to see if there's anything there that could be causing or making the IBS symptoms worse. In terms of dietary, that can come in lots of different formats. It could be making small changes to the diet, or it could be following the first line advice that the dietitian thinks or the doctor thinks that you may benefit from a low FODMAP diet. So FODMAPs stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Very long, and I'm so glad that they've shortened it to FODMAP. These are basically sugars that aren't absorbed properly in the gut, and that can trigger symptoms in individuals with IBS. When the FODMAPs foods are eaten, what happens is they move slowly through the small intestine, which attracts the water into it. And when they reach the large intestine, the gut bacteria uses the FODMAPs as a fuel, as a fuel source to survive. And the bacteria rapidly ferment the FODMAPs, which produce gas as a result. So that happens in everyone, regardless of whether you've got IBS or you haven't. But the difference is that individuals who have got IBS can have problems, for instance, with the speed at which the contents of the food and everything like that are moving through the intestines, which is something we call the motility. Or they may have a sensitive gut wall. So then the extra water and gas in the intestines causes the intestinal wall to stretch and expand. And then that results in the IBS symptoms, such as the pain, the changes in bowel habits, such as the diarrhea and constipation. Other treatments may be medications. So the GP, following the dietary advice, the lifestyle modifications, may also advise that. They could be medications to help relax the gut wall, to reduce the anxiety. They may be bowel specific. There are a few different routes which they may go through. Lifestyle advice is also super important, because IBS is not just about food and drink. And I think that's something that can be commonly forgotten. So there is quite a lot of research highlighting the impact of the gut-brain axis effect, in the sense that the neurons and the activity that's sent from our gut to our brain. So the example I give of that is, if you imagine someone who's got a job interview or something really important coming up, they may suddenly feel that they're having tummy pain and need to suddenly open their bowels, and it may be a looser bowel motion. And that's because of the stress and the impact it's having on the stomach and gut, causing those contractions, which leads to those symptoms. Obviously, that's a very mild version of what's kind of happening in IBS. But again, it's to do with the connectivity between the gut and the brain. So to kind of help with that, we recommend, for instance, reducing stress levels, looking at anxiety. There's evidence for meditation, exercise, physical activity and things, and actually improving the quality of life and the symptoms of IBS. And again, it is symptom-specific advice, depending on what symptoms you've got, as to what the advice would need to be, which could be fibre for constipation, probiotics, eating slowly, little and often, just to name a few. Like I mentioned, there's quite a lot of detail within this in IBS. And I guess what I'd like to leave this slide in IBS on is that it's really important that whatever the advice is, whether it's lifestyle or dietary or anything else, that it's individually and culturally tailored. It should be specific for that person. So that's my really quick run through of IBS. So if there's any questions, and back to you, Sharon, if that's okay.
Thank you so much, Pooja. Before we go to Kavita, who is actually an IBS patient herself, I just want to ask Pooja, we've had someone mention in the chat that FODMAP diet sheets seem to differ in their experience, and some items which are not appropriate in one may be acceptable in another. So what would your advice be to patients in that case? Or is it that they should potentially be reaching out to a registered dietitian rather than trying to follow sheets that they might come across online?
Yeah, I would say with this type of advice, it's really, really important for if you're following the FODMAP, given how strict it has to be, and the way that it's reintroduced, and the way that you cut out foods, and making sure that you don't actually become malnourished, because you are cutting out so many food sources from your diet. It's really important that you do it with the support of a dietitian. Normally you can go through NHS route, through your GP and things, or obviously private is available, but we tend to follow the King's College or Monash low FODMAP diet, and dietitians have a whole host of resources and are able to support through that. It's not something we would, as dietitians, recommend someone undertake by themselves, just because of the risks associated with it, and we wouldn't want someone to end up with deficiencies.
Thank you so much. And Kavita, could you share your experience with us as an IBS patient, and how the diagnosis came about for you?
Yes, of course. And thank you, Pooja, for sharing that. And thank you, Sharon. So I was diagnosed probably about 18 years ago now. I went to the doctors because my symptoms were really bad stomach pain, and I was going about at least 6-7 times a day. And it would mostly be after food, and it would be very like loose bowels. So when I went to the doctors, they at first they actually gave me depression tablets and sent me away. And although I kind of understand where she was coming from, but I wasn't like in depression. I think she was trying to say like it was more the anxiety of it, because I did used to get myself worked up because I'd always need to like pre-plan where I was going, like on, you know, like public transport. I'd always need to see if there was a toilet there. So I guess that was where my anxiety kind of came from. And so when I did finally get, you know, share the symptoms, they did refer me to a specialist. So I did go to hospital, but like Pooja said, there is no kind of treatment, I guess, for IBS. So I did have blood tests, and I had a stool test, and I actually didn't, I don't know why, but I think because of like miscommunication, my blood test didn't come back after like a year when I went back into like the hospital again. So they showed that it was inflamed, but because it had been so long since the blood test, I had to do another blood test. And so yeah, they did. Now then I did get my diagnosis, and it was irritable bowel syndrome. And I also had to do the food map, the keeping up a food diary. And I did notice that there were certain foods that triggered me. So for now, it's I can't like have chili. I can't have a lot of like dairy products, as that like sets it off, and my stomach becomes quite inflamed. And then I will get like a stomach ache, or I will just have to go to the toilet. And medication wise, I didn't really I mean, I'm on quite a lot of medication because I have other health problems as well. So I just got the Buscopan, and I tried a lot of peppermint stuff as well. So I did kind of go down like the herbal peppermint tea way, and that I saw that helped a lot. But it's funny because one day I would kind of like have pizza and it would set me off, but if I had pizza again, I'll be okay. So I think in terms of that, it was like hit and miss, but every day I did used to kind of go to the toilet about at least 6-7 times a day. And then with the social aspect of that, it was I didn't really feel like going out because I've always had to pre-plan where I was going, because when mine happened, I was in secondary school, so a lot of the time it would kind of I'll be like in exams and it would be silent and my stomach would like kind of rumble, and then I think that's where the anxiety kind of came from, because I was like, oh my god, like please, I was like kind of talking to my stomach like, please don't let me down today. And yeah, and then I found as time went on, being a South Asian, a lot of the foods can kind of set me off as well. So yeah, it was more there's a lot of like chili and South Asian foods, so yeah, that's something that really used to set me off. It still does, to be honest. I can't eat chili at all. I've cut that out of my diet. But also having IBS now, I will be honest that I have actually had other stomach issues, so I'm actually looking for another diagnosis now as well, which
that's interesting that you mentioned that. Yeah. We've had a similar question in the chat as well, that, you know, oftentimes the diagnosis will be left at IBS and not investigated further. Pooja, I don't know if you have any advice, or even Professor Seb and Madhur, that if it is left at IBS and you feel that there's something more, is there anything that we can do as patients to make sure that it is being treated as it should be if we feel that it's more than IBS as patients?
Thank you. Yeah, Sharon, I think it's a really difficult one, especially, you know, with current pressures and everything else that's happening. And it is important, if you think something else is going on, to really detail that to the GP or doctor, and let them know all the symptoms and exactly what's going on as well. Because the more detailed history they have, and the more you can kind of show them, hopefully, you know, the more likely they would be to kind of be able to support with that, especially, you know, like Professor Sebastian mentioned, if you have got certain symptoms like mucus, blood in the stools and things, which aren't, you know, typical of IBS and things, that would be a trigger point for them to investigate further. And again, as Professor Sebastian mentioned, nowadays we don't need invasive tests for everything either. It may be that they do a stool sample, you know, a fecal calprotectin, for instance, to have a look to see what's going on there and check the levels. And then they would go based on those results to see if anything further is needed, rather than directly going to colonoscopy or any of those routes where they're putting the tubes in, you know, to check and see what's happening. But I think it is important to go out there and really let them know exactly what's happening and not staying in silence, especially if you do think something else is going on, because we do know our bodies best as well, and we know if something's not right. And especially if you already had IBS and things have started to change, which can happen, especially with age. You know, we unfortunately can get other conditions and other things happening. It's important to re-highlight that. I don't know, Professor Sebastian, or if you've got anything to add.
No, I agree with all of that. I think the key thing, you know, in a conceptually way to understand is that, you know, in IBS in the general, there is nothing really abnormal in the lining as such, but there is a functional problem. It's a definitive problem within the function. So that essentially explains why you shouldn't be having blood and mucus, you shouldn't be becoming anemic, you shouldn't be having nighttime diarrhea waking you up at night, you shouldn't be having accidents very frequently. It's less common with IBS as well. And if you have weight loss or anemia, and if you have any of those, you know, always ask for a non-invasive test. You know, depends on your age. In young people, calprotectin is perfectly reasonable, because your differential or your what you want to differentiate is from Crohn's disease, because a lot of symptoms of Crohn's disease can mimic irritable bowel syndrome, and other things are things like celiac disease, but maybe celiac will be a little bit more clearer with a good history. But if you are later in age, currently there is a new nice guidelines coming out, but currently after the age of 40, you are offered what is called the FIT test, which is a really good test. And if your FIT test is actually normal, it's unlikely that there is any problem with the lining. So even now, while we call IBS as a diagnosis of exclusion, it is still a positive diagnosis, because it is a definite condition. It, in fact, is far more common than any of the other things what we talked about. So it's important to bear that in mind. But at the same time, you know, don't ignore that just because it is IBS, I won't do anything about it, because there are, Pooja has shown, there are a lot of things which we can actually do, particularly from a dietary point of view.
Thank you so much, Professor Seb and Pooja and Kavita, for sharing your experience. Moving on from that, we'll go on to Madhur, who will be talking to us about IBD.
Hello, everyone. Thank you, Sharon and Kavita, and also to Professor Shaji and Pooja as well. And thank you all for allowing me to be part of today's discussion as well. As Sharon mentioned, my name is Madhur, and I am the lead clinical nurse specialist for inflammatory bowel disease at St. Mark's Hospital, which is based in London. So today, in terms of what we want to discuss and what we've discussed so far, you've heard so much from Professor Shaji as well as Pooja, and it's just helping, you know, the South Asian community to sort of, you know, beat the stigma and the taboo that's associated with bowel habits. And of course, you know, your questions have been coming in, and we continue to welcome those. So thank you for that. So just moving on to the other side, to the next slide. Thank you. So many of you, you know, will keep asking the question, you know, what is IBD? So as we know, inflammatory bowel disease is an umbrella term for two main diseases, and it's always known primarily as Crohn's disease and ulcerative colitis. And more recently, I shouldn't say more recently, but we've always known what we refer to as indeterminate colitis, and more recently that has been renamed as IBD-U or IBD unclassified. So inflammatory bowel disease is chronic inflammation of the gastrointestinal tract. And there are ways that we can differentiate Crohn's disease from ulcerative colitis. So Crohn's disease is mainly affected from the mouth to the anus, and ulcerative colitis is mainly affecting the large intestines, or as some of you will say, the large bowel, as well as the anus. And with IBD-U or IBD unclassified or indeterminate colitis, as we still hear it called, it's often where the histopathologist cannot differentiate between Crohn's disease or ulcerative colitis. And we get this quite a lot in our pediatric population, but also in our adult population as well. And as some of you may also hear throughout your diagnosis or throughout your disease course, you would hear other names such as perianal disease, perianal Crohn's disease, proctitis. You hear so many different names and you still wonder whether it is IBD. Yes, it is still IBD. And one of the way of sort of ensuring that we help our patients to understand this is by spending time with them at the time of their diagnosis. And I'm sure that will come up in the panel discussion as well. So if we can move on to the next slide. So some of the main symptoms of inflammatory bowel disease is rectal bleeding, blood in our stools, and diarrhea. And as Pooja and Professor Shaji discussed, you will get an increase in these symptoms if you primarily have inflammatory bowel disease. And obviously coming with diarrhea and rectal bleeding is the increase in mucus production. So that's something that you can sort of, your GP or your doctor can help in differentiating whether, it's primarily IBD or IBS. And we'll go into the diagnostic factors in a minute, where we can demonstrate how it is that we can tell whether it's IBD or IBS. And I am not saying at all that this is, either or, as sometimes it can be difficult to give a definitive diagnosis given the symptoms that each person experiences. Moving on, in terms of the symptoms, you can also have abdominal pains and cramp, swelling of the lining of the bowel, which is also something that you experience in inflammatory bowel disease. Another thing that patients with IBD experience quite a lot of is weight loss, and that is very significant in that symptom also tells you how advanced your symptoms can be, being that you're already anemic or you've already lost your appetite. So all these things, they all tie into one. Fatigue is also another big symptom of IBD, in the sense that you just feel like you have absolutely no energy. And that also, again, stems from your anemia and all the other symptoms that you're having, which contribute to that fatigue. And in addition to that, during sort of some of the symptoms that you will sort of experience as well with your fatigue and everything, you can have bone and joint pains. And moving on in terms of symptoms, and as things gradually worsen in some ways, you can say you end up with symptoms like uveitis, which is obviously inflammation of the eyes. And in terms of your symptoms worsening, quite often patients with one autoimmune problem then tends to develop another autoimmune problem. So that should also be considered by your doctor, your GI physician, your gastroenterologist when they're making that diagnosis. Can we move on to the other slide, please? So in terms of diagnosing inflammatory bowel disease, we've heard so much from Professor Shaji and Pooja with regards to the differentiation in testing for the diagnosis of IBS versus IBD. And I know in the UK, we we probably do things slightly different to other parts of the world. And also the US is quite advanced in some of the things that they do as well. So it all depends on, you know, which region of the globe you live in and what is available to you in that country. But at the end of the day, it's down to holistic care and the symptoms that the patient is experiencing at that time. But to start off, generally, in terms of diagnosis, we will do blood tests, or as the Americans will say, lab testing. You will also have stool testing, and as Professor Shaji and Pooja mentioned, we do now in the UK, if you're over the age of 40, you're generally offer fit testing. And most GPs tend to do fecal calprotectin as well. And fecal calprotectin obviously tells you whether it's specific and whether it's sensitive. So it gives you a little bit of an idea as to what exactly is going on, the level of inflammation in the stool as well. And in terms of diagnosis, there's a host of endoscopy testing that we can do. For those patients who have already got a diagnosis, you know, it involves a colonoscopy, often a flexible sigmoidoscopy, a gastroscopy, which is looking at the upper GI tract, and more recently, capsule endoscopy, which is something that is up and coming, more so in places like Israel and Europe. So some of you may have come across what is referred to as the pill cam. So endoscopy is also, you know, widely used in terms of the monitoring of your inflammatory bowel disease. We use it vastly in terms of surveillance purposes in the UK, and I know it's also used widely across the globe for the same purpose. And generally, as Professor Shaji and Pooja said, you know, there are many tests that you can do that is non-invasive. Endoscopy can be referred to as an invasive procedure. And in terms of the tests that you will do to ensure that you're being monitored or your surveillance is kept up to date is generally a colonoscopy. Again, I don't know what is available to patients across other parts of the globe, but namely the UK and the US and probably places like Australia, it's a colonoscopy. And in terms of diagnosis as well, often you will find that if your GI physician doesn't want to do an endoscopy, sometimes they will do namely CT scans and MRI, and mainly in those patients with inflammatory bowel disease, Crohn's disease type, you find that MRI is most favored. Can we move on to the next slide, please? So in terms of the treatment for your inflammatory bowel disease, I think, again, this is very holistic in the approach that we all use, and I'm sure this will come up in the panel discussion shortly. But you can have patients who, being diagnosed, their symptoms are quite aggressive and they're diagnosed at that point, and they will start off, you know, probably at the top of the treatment ladder, because quite often in inflammatory bowel disease, you have top to bottom treatment or bottom to top treatment. At the very bottom of the treatment ladder for inflammatory bowel disease, you have your anti-inflammatories, which are things like your corticosteroids and your 5-ASA medication. So your corticosteroids are known as prednisolone, or prednisone as it's called in the US, budesonide, also MMX. You have, in terms of your 5-ASA medication, you will also have Asacol, Pentasa, Octasa, Mesavan. There's so many out there. So again, it's all what is available within your region. In terms of the treatment ladder and moving upwards, you have immunosuppressants. So that will be things like azathioprine. Azathioprine is also known as Imuran, and we also have mercaptopurine as well. In those patients who have Crohn's disease, you have methotrexate being available as well. For those patients with ulcerative colitis, you have cyclosporin, which is less used now, but depending again on which region you are in, that is used as rescue therapy. And then you're put onto what we call the next stage, which is the biologics. And biologics cover so many drugs at the moment in terms of, I think initially you all would have known this as mainly as a subcut treatment or an IV treatment, but in more recent years, we have had biologic treatment being in the form of tablet once daily dosing. And at the moment, there's so many biological treatments in the pipeline, so just keep an eye out for those. We also use antibiotics as part of the treatment for inflammatory bowel disease. We use pain relief, and two other sort of treatments that I think that often is overlooked is nutritional support, and the next one being surgery. And I think, especially in the culture that we come from, the community that we come from, we see surgery as a failure generally. And that's something that we need to change the stigma around. We need to change the taboo around that, because surgery for the treatment of IBD is not a failure. Often it's a treatment. So having that opportunity to discuss that with a surgeon and your gastroenterologist and being part of developing that personalized care for yourself as that patient is very important. And we need to change the thought process around the surgical aspect of treatment for IBD. So next slide, if there is one. And that's the end of my little contribution for today. And we'll now open it up to the panel for further discussion. Thank you all.
So we are going to hear next from Sharon, who's going to talk about her experience of IBD. So over to you, Sharon. Thank you.
Thank you so much, Kavita, and thank you, Mother, for sharing. That is very useful to hear. I'm Sharon, as I've said before, and I was diagnosed with Crohn's back in 2002, so it's been just over 20 years for me. The diagnosis process was fairly quick, I would say. I was diagnosed within 6 months of symptoms starting for me. It came on with abdominal pain and diarrhea, and at first my GP was very resistant to refer me on to a specialist because they felt that it could be indigestion, and there were also concerns about the weight loss or the lack of weight gain. I think eating disorders kind of came into the conversation as well, just trying to figure out what was going on. But I deteriorated so quickly that they had no option but to refer me on to a specialist. And then from there, the diagnosis came fairly quickly. After a year after my diagnosis, I did then have surgery, a right hemicolectomy to remove part of my colon. And at that time in 2003, that felt like the best option for me. As Mother mentioned, surgery is absolutely a treatment option as well, especially if other medication isn't available to you. And at that time, it wasn't for me. Infliximab was fairly new in the UK, and they felt that my case wasn't severe enough for it to be approved. So my pediatrician felt that if they were to do surgery, then they would start me on azathioprine after, which worked very well for me. I stayed well on azathioprine for a couple of years. Did start to flare again, unfortunately, as I went to university. Stress, I think, can be a very common trigger for patients with IBD. So I think just the stress of being at university and not really knowing how to manage my condition, and also dealing with transitioning to adult care at the time, I think combining all of that together led to a very stressful time. I felt that I kind of fell through the cracks. I wasn't being cared for as well as I was as a pediatric patient. So I spent almost 5 years on prednisolone while I was at university, which of course isn't advised to stay on steroids for such a long period, especially with younger patients. But I did eventually transfer my care to a different GI clinician who, of course, was very upset that I had been on steroids for so long with no other kind of treatment option offered. So he treated me as if I had just been newly diagnosed. From there, he did the colonoscopy, everything from the beginning, and I was put onto infliximab, which for me was a miracle drug. As soon as I started, I felt better immediately, but unfortunately, the 8 weekly intervals weren't enough for me. So then I was switched on to adalimumab quite soon after. I stayed well on adalimumab for quite some time, also known as Humira. But then I did develop a stricture in 2013, which is a narrowing of the bowel, which led to surgery. And then I had further surgery. So I had a subtotal colectomy, and then they formed an ileostomy as well. An ileostomy is where a part of your bowel is taken out, and then a bag is kind of placed on top of it. So your stools kind of come out into the bag rather than going the usual way. I had that for almost 3 years. At first, I was very reluctant to want to keep it. Of course, I didn't have the choice of having it removed, but they did kind of go into the surgery telling me that it would only be for 3 months. So I thought, okay, I just need to get through these 3 months, and then I can have the bag taken down and I'll be fine. But of course, at the 3-month mark, I was still very underweight. My surgeon wasn't really happy for me to have more surgery. So I was advised to give it at least 6 months to see how I do. I would say around the 6-month mark is where I started to feel comfortable with the ileostomy bag, and then from there on, it just felt like it was a part of me. Once you figure out the right supplies, and you're not leaking on a regular basis, and your skin is looked after very well, it actually opened up my diet quite dramatically. I was able to do more. I had more energy, but I did eventually then go ahead and agree to have the stoma reversed at the 2 year. Around 2.5 years is when they agreed that they were happy for me to have it reversed. And I think part of that came from, with the South Asian community, there's always other factors, like marriageability comes into it in a big way. And I kind of felt that having a stoma bag would potentially make things harder for me. So looking back, I feel like I didn't really make the right decision based on my health. I was thinking about other social factors, which as patients, we shouldn't need to, but it's always there in the back of our minds. I think Kavita mentioned as well that the social aspect with having to go so often in the day can take away from your life so much, and it can leave you feeling quite isolated and not really knowing how to socialize anymore, or feeling comfortable with doing so. So there are always other factors, I think, that play into what we decide to do with our care. But after my reversal, I did flare again, and then I was switched on to ustekinumab. I have been well on that for a couple of years now, but I will say, as Madhu mentioned, that it's definitely important to discuss all treatment options that are available to you. I think someone mentioned in the chat that they I think so someone mentioned in the chat that they've become allergic to infliximab and resistant to other meds. They're currently on adalimumab, which is not showing a high enough level. So they've been told that that's their last option before surgery. Professor Seb, I wondered if you could touch on this.
Yeah.
Is it right that?
No, it's obviously I don't know the specific situation why the surgery is recommended. As Madhu pointed out, surgery is the right option for some, but infliximab and adalimumab are essentially same in relation to how they work. And many people whom in infliximab has stopped working, some of them work with adalimumab. But if both of them are not working, in a simplistic way of putting is that your disease is not driven by that pathway, which is interfered by those two drugs. So it may be a different pathway. And there are a number of other classes of medications which works through different pathways. So in the UK, at least there are 3 other classes available. There are 2 or 3 on the pipeline for this year and next year. So certainly that is not the end of the road in relation to biologics. Obviously, I can't tell you specifically on this questionnaire as a specific condition. There are some situations in which surgery is the right option. Indeed, it may well be the right option there, but medications, there are other options available.
Thank you. And I will say that because with my first surgery, it was planned surgery, and going into it, I felt much more confident. I was aware that, obviously I was having surgery. My weight was at a comfortable place. So the recovery was actually much quicker. And because we planned to go into it, I wasn't just thrown into needing surgery. Whereas the second surgery I had, the subtotal colectomy, it happened because the stricture became completely obstructed. So I needed emergency surgery. My weight dropped dramatically. So the recovery after that was quite lengthy, and it can really take a toll on you. So it's definitely something worth discussing with your clinician and going, not leaving it as a last resort if it could be an option to improve the quality of your life. I would say, as an IBD patient, my priority has always been to ensure that my quality of life can be as the best as it can, whether that's with medication or having had the surgery that I've had. And I just want to, I know we've run over time a little bit, so we're going to just run for maybe about 5-10 minutes extra to answer some of the questions that we may have missed. So we want to thank you first for all of you for being so engaged for the entire webinar. We hope this has been helpful for you. And this is being recorded, so if you do need to drop off, then you can always check back later. We will be uploading on all of our channels, on South Asian IBD Alliance's YouTube, on Chronically Brown's YouTube, and Guts UK Charity will be sharing the recording from this webinar as well. But Professor Seb and Madhur, we did have the question come in asking, should it be painful to pass stools in IBD even if you're in remission, assuming that they are a normal consistency?
Madhu, do you want to take it?
Thank you, Professor Charji, and thank you, Sharon. So yes, you can have painful motions, and you can have difficulties in terms of passing stools. And often, sometimes patients can end up in remission. And what they can have sometimes is when they do start flaring again, they have the very bottom of their anal tract becoming inflamed. And if that is inflamed, then sometimes it prevents the rest of your stools passing. And if you do pass your stools as well, through that anal tract, you have pain, you will find it difficult to pass your stools. And often that is where sometimes you treat patients with topical treatment in the form of rectal enemas or rectal suppositories. So yes, you can have difficulty in passing stools, and it can be painful as well.
Thank you. And just another question we had is, higher sugar intake in association with worsening inflammation in IBD?
Yeah, it's a fascinating area of research, and I should say I'm going to plug research to all of the participants, because as Sharon has just mentioned, it's only through research over the last 15 years we have so many new therapies available for inflammatory bowel disease, and probably for other conditions as well, like Pooja mentioned, for IBS as well. So do participate whenever you are able to in research. So this is one of the areas of hot research. At the moment, everything is what we call as association. So that means people who have used sugary drinks and fizzy drinks for a period of time appear to have more IBD, more so with the UC than Crohn's. And similarly, questionnaire studies. So if you ask patients who have IBD, or you particularly, you see, they might say, at least a proportion of them say that when they actually use sugary stuff, then they may have a flare. They are associating. So these are what are called association studies. Is there more to it at more deeper scientific level? Potentially, yes. And that's something what we ourselves are looking at. We know that this sugary stuff changes how the lining of your bowel is. It can, change what we call as permeability. What that means is that whether there is leakage of the lining. It can also change how your bacteria in your gut is. So there may be changes in relation to what you eat, and that can change bacteria in the gut. And our current hypothesis, at least, is that it is the change in that environment in the gut, mainly the bacteria, or we call it microbiome, is what is the trigger for inflammatory bowel disease in a genetically susceptible individual. So theoretically, there's a really great question, whoever asked that. It's an area of hot research, the link between diet and microbiome, and I strongly encourage you to contribute to that research.
Thank you so much, Professor Seb. And with that, I just want to thank all of our gut experts today for joining us. Thank you so much for your informative sessions, and thank you to my co-host Kavita for joining as well and sharing her experience. And thank you to everyone for joining in, and we've loved all of your questions. It's been so engaging. We apologize if we weren't able to get to any of the questions, but I did see Professor Seb and Pooja handling a lot of the questions in the chat as well, so thank you for that. A special thank you to Guts UK for bringing this webinar together with us, for collaborating with South Asian IBD Alliance and Chronically Brown. We absolutely love working with the charity. We think the awareness and everything they do for digestive conditions is incredible, because the awareness is needed in all areas with digestive conditions. It's so important. So we hope to bring together another session like this in the future. And a special thank you to Chloe and Esther, who've been working behind the scenes from Guts UK to coordinate this chat tonight. And before we do go, we've dropped some links in the chat for South Asian IBD Alliance and Chronically Brown, and for the individual gut experts as well. And if I think it was mentioned earlier in the chat that Guts UK actually have a tutorial tool on their website, which allows you to check the frequency, color, and consistency of your stools to see if the bowel habits are normal or if you should be contacting your doctor. So please do check out that tool. It's fantastic. And as we've all mentioned, please do check your poo on a regular basis so that you can get the help that you need early rather than leaving things too late. Thank you so much.